First, before we start, we are the Active Partnership for Berkshire, one of 43 nationally, and we seek to harness the power of physical activity and sport to tackle inequalities and transform lives and communities. Our role is to work collaboratively with local partners in a whole systems approach, identifying and dismantling barriers that prevent individuals and communities from being more active. It's really great to see lots of familiar faces on the call, as well as lots of new ones too. So again, thank you very much for joining us, and we look forward to remaining connected with you in the future. We feel very, very lucky to have secured a very high calibre programme of speakers, and we are super grateful for them giving us their time today. I'm just going to run through a little bit about our speakers now. So Professor Dawn Skelton will start. Dawn is a Professor of Ageing and Health at Glasgow Caledonian University and is also the chair of the British Geriatric Society Rehab Group and a member of the National Falls Prevention Coordination Group. Dawn is going to provide an introduction to frailty for us and how it interacts with other factors and conditions, such as falls and sedentary behaviour. We've then got Steve and Chris delivering a presentation as a bit of a double act. Steve is the CEO and Chris is a member champion from the British Association of Sport Rehabilitators. Steve is also a lecturer in sport rehabilitation in the School of Health and Society at the University of Salford and works with national bodies including HEE on topics around exercise prescription, physical activity and behaviour change for long-term health conditions. Chris is currently a doctoral in elite performance, has an MSc in sports medicine and is a certified strength and conditioning specialist. Their presentation is going to provide some expertise highlights focused on strength training, including behaviour change and patient-centred approaches, screening and safety, and taking into consideration some common long-term health conditions that you're likely to come across. We're then going to have a short break after Steve and Chris, and then Dr. Fiona Duncan is going to be speaking next. Fiona works as a GP and specialty doctor in geriatrics. She's the primary care clinical lead for older persons' health and enhanced health in care homes for North Devon. Fiona is going to talk to us about a reconditioning initiative for care home residents in North Devon. And our last keynote is another double act from Dr. Jitka Vestekova. I hope I've got that right, Jitka, and Rachel Miller are presenting a new initiative designed to engage people over 50 in ageing well habits. The Ageing Well Pledge is based on the 5 pillars of ageing well and offers 5 steps to a longer, healthier life. So you'll be hearing a bit more about that. Jitka is an academic focusing on ageing well and has worked on the Ageing Well public talk series, and Rachel is a public engagement person who is passionate about bringing science to people. Okay, so we've got our first poll coming up. So on your phones, you need to navigate to slido.com. And this is our first question. So once you get to slido.com, if you enter hashtag LLB01, you can see it on the slide there, or you can scan the QR code, it should automatically bring this question up for you. So the first one we're asking is, on a scale of 1 to 10, with 10 being the most important, how important is physical activity to you with regards to preventing, delaying and managing frailty? There's no right or wrong answer to this one. It's just to get a sense of what the feeling is in the room. This is great. It's good to see people obviously getting in okay. Give you a few more seconds on this one. Okay, I'm going to move on. So our next question, on a scale of 1 to 10, how confident are you when having conversations about and/or prescribing physical activity with the aim to prevent, delay and manage frailty? Again, just a kind of gut feeling on this one. Already a good range there. Last few seconds on this one. Thank you very much for submitting responses. Okay, super. I'm going to move on, conscious of timings. Thank you very much, everybody. A good range there. Okay, Dawn, over to you.
Thank you, and welcome everybody. My challenge is to explain a little bit more about frailty and falls to you before you hear about all the things we can do to help prevent and manage that. Essentially, I'm, as you've heard, a Professor of Ageing and Health at Glasgow Caledonian University, and also I'm a Director of Later Life Training. And there's a little bit of a joke going on there. So you have sprouts. It's got something to do with couch potatoes sitting too long. And that's really where I'm going to come from in a lot of this. Frailty can hit all of us, but it's far more likely to hit us if we're sedentary. And therefore, we're starting from a different base about how we have conversations with people who are frailer. If I can have the next slide, please. So what I'm going to cover is a little bit about what is frailty, how we might assess it, and the effects it'll have on health and independence, and the compounding effect of COVID-19, not just the social restrictions, but also if you actually got COVID-19. So that's what I'm going to cover a little bit in this 20-minute presentation. Next slide, please. So what is frailty? I think we probably all have an image in our head about someone who's frail. And essentially that's frailty. It's someone who's got multiple things in their lives, whether that be health, whether that be fitness, whether it be depression, all sorts of things which might come together, which affect how we age and how we age successfully. And we actually all start aging from about the age of 30, believe it or not. That's when we start losing muscle function and balance and all sorts of things. But we've got so much reserve, we don't really notice it. And it's those reserves that become less and less, such that suddenly something simple like a bad cold or a urinary tract infection puts you out of action for a few days, and you're in a very different state when that's clearing up. But the interesting thing here is that most people presume that once you're frail, you're just going to stay there, and it's just going to get worse. But actually, frailty is not static for an individual. It can be made better. Generally, sadly, it tends to be on a single trajectory, but it can be made better. If I can have the next slide. So on the left is a visual picture of frailty. Essentially, it's characterized by weakness, a slow walking pace, low levels of activity, which has probably led to the first two, fatigue or exhaustion, and usually, and particularly at the frailer end of the frail, unintentional weight loss. But not all frail people have disabilities, and not all frail people have comorbidities. It can literally be a very individual thing depending on the lifestyle, the health characteristics, and the physical activity patterns of an individual. So to give you an example, if you wanted to think about disability, comorbidity, and frailty, only about 20% of people have all of those three that might be characterized as frail. One activity of daily living is when you start considering a potential for disability. So having difficulty with an individual activity of daily living, and I'll come back to that a little bit more. We do know that frailer older people usually are comorbid. They have multiple health conditions, and often that's why they've been avoiding activity, because they're not sure what to do with those conditions and how that's going to affect whether it's good or bad to be active with that. Next slide, please. So this, I'm not expecting you to read all of this, but essentially there's a couple of things to remember as we get older. So along the middle is just age as we get older, and on the top part of the graph is as we get older, our physiological systems start breaking down a bit. Various things will start happening. Endocrine function doesn't work so well. We don't produce the right hormones at the right time. We perhaps are not coordinating everything so well with our nervous system. And what that leads to is the bottom part of that graph is a progressive, usually, decline in physical function, eventually to the point at which people become dependent on others. But as I said, physical activity, frailty, these are not static states, and we should be able to intervene at many points along that pathway. Next slide, please. So how many people are frail? Well, perhaps not as many as you thought. Around 10% of over 65s have some form of frailty, and that rises, depending on how you measure frailty, to between a quarter and a half of all of those over 85. I think it's fair to say if you go into a care home environment, then you're going to be looking at probably 90% are frail, if not more. What does this mean for our healthcare systems? Well, it means quite a lot of extra money. So there's been a big piece of work by Han et al. Published a couple of years ago that showed the additional cost of somebody going into a healthcare system with frailty is considerable. So if they've got severe frailty, the additional cost compared to someone else at the same age without frailty is at least £2,000 per individual. So that's costing our NHS an additional £5.8 billion per year across the UK. A lot of money. So frailty costs. And frailty leads to falls. So one of the key things we'll see is that there could be something quite minor and suddenly they'll fall. And frailty falls are definitely one of the biggest symptoms of falls, but it also means that they are less able to interact with being physically active safely. Next slide, please. So how do we assess it? I'm not expecting you to all go away and become experts on assessing frailty, but there's something very simple called the clinical frailty scale. And if you look on the right on that quite busy diagram, anything above the red line is what I would call the non-frail to the starting to get quite frail. So the very fit, the person who's still quite happy to engage in outdoor activity, to the vulnerable, someone who's still engaging in some outdoor activity, but perhaps uses a walking stick or is avoiding certain things that they feel less comfortable with. And then below that red line are where we start seeing the transition to it becoming quite difficult to engage people in activity because of their frailty. So mild, frail, up to obviously terminally ill. But it's a simple thing. If they slow walk, if they use a walker, if they've got a care package, if they've got multiple medical conditions, and particularly in blue, if they're avoiding activity because of fear of falling or worries about their health, then that means they're almost certainly moving into frailty. The next slide, please. But of course, we have a big range, and some people successfully age, like the lady on the right-hand side at the top. In fact, both those ladies are 82. So it makes no difference what age you are. It makes a difference on your trajectory to get there, and whether you stay resilient or whether you move into frailty and cross a disability threshold. The issue is what makes somebody perhaps cross into that threshold. And I ask for the next slide, because really there are three key things that remind us about frailty. It's much more common as we get older, and it's much more common with multiple diseases. But disuse or lack of activity is one of the key things that can tip somebody into frailty much earlier. The next slide really shows the problem we've got. This is the amount of people who meet both the aerobic and the muscle strengthening physical activity guidelines by age and sex. This is particularly data from Scotland, but you'll see that once you hit over 65, it's less than 15% are meeting those guidelines. And once you hit the 75s, it's 5%-ish. So there's such a small number of people who are being active enough to maintain health at these ages that they're much more likely to tip into frailty. Next slide. And this, again, is perhaps one of the issues, and we all need to be aware of this, actually. Anything from about the age of 50 is going to start noticing this. This is a person's day where they spend a fair amount of their time sitting. It could be social, it could be reading, it could be hobbies, it could be having lunch, watching television, eating. But essentially, there's about 30 minutes of active time in that day. They're meeting the physical activity guidelines. But we know that sedentary behaviour is an independent risk factor for frailty and for falls. And we know that sedentary behaviour increases with age and is far more common in people who are frail. So there's our first aspect about how we actually engage them in activity beyond just meeting that guideline, if they're sitting the rest of the time, it may be negating the effect of that walking period. Next slide, please. So inactivity and frailty, this just shows you the trajectory that can happen. So over a 4-year period, those who were less active became more frail, those who were frail sat more. It was a unidirectional relationship. And we know that actually those who self-report sitting for 8 hours of their waking day or more are 3 times more likely to be diagnosed with frailty than those that sit for less than 4 hours. So a trajectory again of physical activity and the effect that'll have on frailty. Next slide, please. What happens when people sit all day? Well, generally, they'll see a reduced range of motion. They'll become more stiff. That means, of course, they become less active because they're stiff. They might end up getting a bit more pain. We certainly see bone loss and muscle loss over time. Their balance gets worse. They've got poor venous return, which means they get more dizziness on standing. And all of these things essentially can affect the psychological aspects of aging as well, and a sort of lack of motivation to do much at all. And we know from studies where they've literally sat people down deliberately for long periods that it can have quite a big effect on somebody in quite a short period of time. But of course, it becomes normal if that's what they always do. So again, it's really difficult to break that up. Next slide, please. So what does that really mean? Well, we know that ideally we want to do something about breaking up sedentary behaviour, because that in itself will make quite a big difference to where somebody moves forward in their trajectory. We know that, as I say, an independent effect of sedentary behaviour is increased frailty and increased falls, on top of various problems which might increase your risk of stroke and heart attack. Next slide, please. Excuse me. And I come back to being fearful of movement once somebody is frail. So we know that fear of falling leads to reduced activity, both indoors and outdoors. We know that fear of falling also increases our risk of frailty. We know that if we are fearful and avoiding activity, we are more likely to become a repeat faller and have injurious falls over the next 8 years. We know that basically there's a 1/4 increased risk of falling in those who sit for longest. And hip fractures are far more likely in those with frailty. So this is a group we want to do something about, to change the trajectory. But of course, it also means we want to do something to stop people becoming frail and fearful of activity in the first place. Next slide, please. Just a couple of comments about cost again. Believe it or not, 1/5 of over 75s who go into hospital are frail, and they account for half of all hospitalisation days. And of course, they're the ones that we find difficulty discharging back to their own home and have to find care packages for often. So to give you an idea, in looking at an orthopaedic unit on the right-hand side, total length of stay can be 3 times as long if someone is frail than if they're considered pre-frail. Up to half of older adults will leave hospital with more risk, more concern about falls and more worry about movement, which means, sadly, that hospital admission in the past 12 months is the single most predictive risk of functional decline, because they're decreasing their activity. So we need to start at every aspect that we come across older adults who are frail. We need to all sing from the same song sheet about moving more. Next slide. Here's Tommy's story, just very, very briefly. A chance where we could have intervened at so many points. So he lived independently with a cane. He walked around with a cane, but he was having a few falls. He wasn't referred to a falls clinic. Eventually, sadly, he did fall and break his hip. He spent 2 months in hospital, severely deconditioned, didn't move. Coming out was an absolute nightmare. So many missed opportunities. If he had been referred at the point at which he'd had some falls, if somebody had engaged with him to be more active so that he didn't require the cane, all of these things might have changed that trajectory of Tommy. Next slide, please. And then, of course, we had COVID. This is actually just a graph, and I know it's quite busy, but I just want to explain a couple of bits on it. This is the length of stay in people who got COVID during the 2020-2021 period, and you'll see that essentially those who are most frail, that's the red line at the top, had a much longer length of stay, so up to 75% of them stayed for at least 20 days, compared to but less than a much shorter period for people who are much less frail. So frailty obviously meant you were less likely to survive COVID, but also you're more likely to spend time in hospital. And the next slide shows that actually even those that recovered and went home, their odds ratio for having mobility difficulties or being physically active was much worse. So having COVID means that we're more likely to have difficulties with household activities, we're more likely to be inactive, our physical activity to go down, and we're more likely to have difficulties with standing up after sitting. So all of these issues mean that we really need to do something about this pandemic of rehabilitation that's due from the increased frailty due to COVID. Next slide, please. During COVID, the first 3 months, Public Health England did a piece of work to look at the increased falls that may occur as a result of people reducing their strength and balance activity. So this was modelled looking at all the studies which have looked at increasing physical activity on falls. And Sport England had done a piece of work, of course, with people who are digitally engaged and filling in surveys. So frailer older people don't tend to do those. So this is an underestimate. But what you'll see is that they predicted an additional 250,000 falls in 100,000 people, costing 211 million just from the first 3 months of lockdown. What we do know is that even now, community activities and clubs are less well attended than they were pre-COVID. There are less older volunteers and people are doing less activity. So we know from a recent review in Nature that generally in all surveys across the world, older people's physical activity levels dropped significantly post-COVID and have stayed reduced. And of course, rehabilitation services are also not at full capacity, and that means that often people are not getting the type of activity intervention at the time that's needed. Next slide, please. So nearly finishing up on, and hopefully we'll go to some more positive conversations about what we can do about this after. But this was a recent survey of NHS services across the UK about what they looked at in terms of sarcopenia, that's the additional loss of muscle with age than would be expected, and frailty. So first of all, no NHS service at all looked at sarcopenia and whether someone had much lower muscle function and strength than they should have. They often use the clinical frailty scale, which I showed you earlier, but really sadly, less than half were offered any form of exercise therapy when people had determined that they had problems with everyday activities, in other words, were frail. So the NHS is not kickstarting this at the point at which people are discharged from hospital. That's the first thing. Next slide, please. We can find people who are transitioning to frailty. One example is the functional fitness MOT, which some of you may have heard of, where essentially there's normative data across the age range for some different functional tasks. So if you look at the graph on the left, if I was a woman aged 75 and I managed, say, 12 sit to stands, I'd be between those two grey lines, which is good for that age. And I would be, you know, thumbs up, you're doing pretty well. But if I was only managing 3 sit to stands in 30 seconds, when I was age 60, that should be a red flag for this person could do with something intervening to make a difference to muscle strength and balance and other things which change physical activity trajectories. So it is possible. For example, you should be able to stand on one leg for 10 seconds. If you can stand on one leg for 10 seconds, you vastly reduce your chance of falls or fractures. But most people actually in their 60s can't stand on one leg for 10 seconds. So again, that would trigger or should trigger some form of discussion about balance training and the importance of. Next slide, please. So intervening early would be great because we'd have less people becoming frail. If we could change their physical activity and particularly their strength and balance trajectory, we might be able to get them to that green line rather than that blue line. But there are a number of times, and if you could just click the slide for me again, that transition where we change our physical activity. So, for example, at retirement, when we take on caring duties, when we have a few falls, when we're diagnosed with a new medical condition, all of these things can make quite a big difference to whether we increase or decrease our physical activity. They're really good time points to talk to people about the importance of being active and having strength and balance work in there. Next transition on the slide, please. And all of these people in blue are people that come across older adults in these transition points and could make a huge difference. With the introduction of social prescribing and health and wellbeing coaches, etc., perfect time point again to have a conversation with someone about the importance of strength and balance. Maybe get them to stand on one leg and see if they can. And we could perhaps make quite a big difference to trajectories. Next slide, please. So just finishing on there, frailty is not static. We could intervene if we catch people at the right point. We should all be promoting physical activity, particularly breaking up periods of sitting. We should be looking at effective interventions to reverse frailty, which you're going to hear about more in the next couple of speakers. And essentially, let's not think about wrapping people up in cotton wool because they look frail. Let's think about constantly promoting and banging that drum about the importance of strength and balance and physical activity as we age. Thank you.
Dawn, thank you so much for perfectly setting the scene there on the topic that we've got today, and big gold star for you to keeping exactly to your 20 minutes as well. That was perfect, and it leads us on brilliantly now to Steve and Chris, who are going to, as you were alluding to there, talking a bit more about what can we do to help. So Steve and Chris, I'll pass over to you.
Thank you very much. Can we have the first slide? Thank you. So I kind of come from a sports rehab background. The pictures on the first slide are our university clinic that's been going for nearly 2 decades now, and we actually see a huge number and have been seeing a huge number of quite frail patients coming from quite socially disadvantaged and economically disadvantaged backgrounds, and we've kind of been working with them using exercise rehabilitation for a very, very long time, and we've seen some kind of fantastic changes there. And one of the things you certainly get to see is the difference that kind of exercise interventions and lifestyle can actually kind of make. Next slide, please. One thing that's really important from the outset to say, I'm incredibly biased about this, and I have to be quite careful. Exercise isn't this unassailable kind of panacea that's, it's the perfect medicine for absolutely everything. It really isn't. Everything is intertwined. Even things like kind of bone health, they don't exist in isolation. From an exercise perspective, we've got to think about kind of the metabolic background, the hormonal background, and we've got to think about kind of the social background as well. And there's lots of routes into how we can treat patients, and sometimes it's kind of counterintuitive. When I started off in my kind of early days of practice, I was definitely a lot more about exercise. And now I'm definitely more about how we look at routes into changing a person's life. And that might be going down the line of actually kind of looking at, say, for example, kind of craft clubs. It might be kind of green gyms. It might be gardening clubs. It might be social activities. It might be kind of gateways into something else. And then we can start adding in, kind of different forms of exercise. And again, this is about resistance training. A lot of the stuff we're kind of talking about today, but that doesn't exist in a silo. Aerobic training, we think about kind of balance, we think about everything else that sits around it. It's all incredibly, incredibly important. And it's certainly been a bit of a journey for me. And as I say, I do need to be careful about my bias because we love exercise as a family. We're never inactive. We're always, always active. Next slide, please. So some of the kind of key questions we're going to whip through today. You'll notice on some of the slides, I am not going to kind of hesitate for very long. They're there more for kind of reference. I'm going to draw your attention to them and why they might be useful. And I'm going to move on fairly quickly. This is very much a whistle-stop tour. But there's obviously some very, very kind of key questions here. why are we exercising, what we're getting from it, you know, and how safe is it for our patients? And that's probably the big one, isn't it? For a lot of kind of healthcare practitioners, a lot of kind of exercise specialists, you know, it's quite scary getting those patients in front of us if they've got multiple comorbidities. They've got cardiovascular disease, maybe osteoporotic as well. They've got various kind of metabolic issues. It can be quite scary, you know, trying to think about how we get that person to exercise safely, and it's our responsibility to make sure they're safe. So we'll have a bit of a chat about that. Probably one of the most important things we need to consider is how we kind of facilitate behaviour change. So I'll give you kind of a few options and a few routes and hopefully a few ideas to think about in that area, because that's probably the most important thing we do with patients. If we're really going to change someone's lives, especially if we catch them a little bit earlier, we have to be really, really good at the behaviour change. That's incredibly important. And then obviously we're going to have a chat about some of the common conditions as well. And as I say, I've tried to put links in, you'll get this in PDF, you'll get this as a presentation. I've put links to open source resources. So there's stuff you can access, and you don't need to actually be able to get through the paywall as well. So I've tried to make sure it's easy for you all to access. Next slide, please. Just a quickie, we'll see loads of figures like this, and you can argue about the exact numbers, you can argue about the, you know, the kind of money involved, but the unassailable fact is, you know, it costs us a lot of money. You know, kind of Dawn's given us an absolutely kind of fantastic overview of what's actually happening in the UK, and the situation is very, very similar globally as well, and it's costing us not only in money terms, but in terms of society as well. And think about the impact on a patient's family, everybody around them, on what happens as people become frail. So it's not just about the numbers, but the numbers are clearly quite important. Next slide, please. So this is kind of a fairly important question really about, obviously, is it safe? Quite luckily, we've had lots of really, really good studies come out over the last few years, especially looking more in depth at kind of safety, at things like kind of resistance training, you know, and what we can actually kind of do with patients. This particular study, it was one of the really kind of strong points around it was looking at very, very high risk patients. So this is the kind of patient that, you know, several years ago, you might go in front of you and you think, I'm not getting them exercising. But one of the things we do see from studies like this is that actually the people who are exercising, and we're talking about resistance training as well, that's one of the areas that has been studied in this particular study, we can see it is incredibly safe, and it is a lot safer than if we don't exercise. Now, that does not mean you can do what you want, because we still have to think about screening. We still have to think, you know, okay, this patient in front of me, you know, what's their history? What are the things that I really need to think about? Do they have cardiovascular disease? Do they have rheumatoid arthritis? You know, do they have kind of osteoporosis? Do they have a whole combination? And there's lots of things we can do to make things a lot safer, which is really, really important. So we know it's going to obviously kind of benefit, you know, kind of all-cause mortality, you know, kind of cardiovascular disease incidents as well. It reduces as well the risk of cardiovascular events. And again, this is obviously kind of something that this study looked at in particular. And we think about things as well, like kind of patients who are undergoing treatment as they have cancer. We think about MSK pain as well, although we'll chat about that a little bit more because the effects are actually surprisingly low sometimes, but the overall benefits of exercise are incredibly important. And we obviously think about things as well, like kind of increasing control for type 2 diabetes. And we think about fatigue and how we change kind of mitochondrial health as well. That's incredibly important. And if anyone's interested in kind of a deeper dive into how a lot of these things work, there's a lot of research now around kind of myokines, around adipokines, and the pathways that then follow on that have very beneficial effects on our bodies and our health and our functional ability as well. One of the things you notice around kind of resistance training for this particular study, the big mediators and improvements in mortality risk were actually things like kind of systemic inflammation and insulin resistance as well. So we think about things like kind of upregulation of GLUT4 receptors and everything that surrounds that. So it's incredibly important. And you know, we think about these numbers and we think, yeah, that's absolutely brilliant. And sometimes we also forget, you know, what it means to the actual patients as well. And there's just kind of a few patients I was kind of thinking about that come to mind when I think about this. Probably the biggest kind of effect on me as a practitioner was from quite some time ago. It was a lady who had been sat downstairs in her house. She'd not been upstairs for 12 months. She was being brought all her meals. She was incredibly frail, and she was brought into our clinic by her neighbours. And our students, not experts by any stretch of the imagination, not amazing in everything they do, but they were safe. They worked with her for several months, and she went from the position of where she thought her life was over and she was just waiting to die, sat in the bottom of her house, not being able to go anywhere, and she got back her ability to stand up, to walk, to actually get out and about, to go to clubs, to go upstairs. And it wasn't a quick process, but it was probably one of the most dramatic changes I've ever seen. And she did an interview for the university newspaper many years ago, and her words were it gave her life back and a reason to live. And then from that, we have lots of other kind of patients as well. You know, we've got 80-year-old kind of rheumatoid arthritis, patients with rheumatoid arthritis. You know, they've had an active rheumatoid arthritis for 60 years, lots of significant functional impairments, having to use kind of mobility scooters, and they can go from pathways from going to actually kind of starting social activities, craft clubs, to actually just speaking to that same patient who's now doing Tai Chi in her garden at 5 o'clock and 5:30 in the morning and starting to add in knee bends and starting to get some strength that way. And for her, that is strength training. To the 70-year-old who 2 years ago, retired social worker, he had metabolic issues, he was starting multiple medications, very inactive, started to struggle to get upstairs. His pathway was through kind of aerobic exercise initially, so started off biking, then mountain biking, then strength training, and now he's in a position where he's going out all day and he's actually taking out his granddaughters, you know, and living a really, really active life. And he's now really looking forward to retirement, and he was starting to get a bit depressed about retirement before that. So there's lots of things we've actually kind of got going for us now as well. At the bottom there, there's a load of papers over the last 12 months around kind of no time to lift and how we design efficient training programs, and kind of exercise snacking as well feeds into that, not just about aerobic exercise snacking, but resistance training type snacking. And Chris will talk a bit more about that. And the next slide, please. This is something we see all the time. I put it up here because, I mean, most of you hopefully have seen it and can utilise it. Probably one of my points here is that I don't get bogged down with this. What I do get bogged down with is that patient in front of me, and what I think is going to be reasonable and appropriate pathway to them is going to be realistic. That's a really important thing for me. This is kind of, you know, if I told people to do this and they all did it, absolutely amazing, absolutely brilliant. But we know that doesn't work. So it's good to have these things. It's good to share these things with patients when we feel it's appropriate. And it's brilliant, as I say, to have all these kind of infographics as well. But don't become too bogged down with them. Think about the person in front of you. And the next slide, please. Now, Moving Medicine, they've created loads of fantastic resources. There's loads of bodies around this, around this area in the UK, produced tons and tons of base information. Some of the kind of the GP kind of CPD forums, some of the Welsh ones are absolutely brilliant as well. There's tons of stuff in there. Moving Medicine has loads of great things, and you can use these infographics and you can download these infographics for your use with patients if you want to present as well. But if you go to Moving Medicine, there's lots of information. There's lots of kind of CPD learning for all of you on there, which is really, really good. Now, we've said already, the benefits outweigh the risks, and the risk of adverse events is very low. But one of the things I'm certainly kind of quite careful of is thinking about that patient in front of us as well. So say, for example, we have the patient with diabetes who comes in to see us. If I know they've got retinopathy, I know they've got peripheral neuropathies, I've got a good idea. There's obviously kind of a number of things going on with their cardiovascular system as well. So that means I'm going to start off really, really slowly with patients like that. And if I'm starting off with resistance training, it is going to be very gradual, and it's definitely not going to be to failure, and it's not going to be kind of stacking multiple sets on top of one another. I'm going to think very, very carefully about what's happening to them. Think about understanding kind of physiology. What do we expect to happen to a patient? What do we expect to happen to their heart rate as they exercise, their breathing? You know, what's going on if actually they start to lose focus, if they start to get pain in different areas, if they get chest pain, that's kind of an obvious one. But if they start to become a bit dizzy, they become unfocused, you know, there's issues around that. We need to understand the basic kind of physiological effects and what happens when we exercise. That's really, really important. So we can kind of monitor patients. We start them off slowly. We have very long warm-ups. We allow time for vasodilation of our coronary arteries. So if there is any kind of evidence of kind of cardiovascular disease, or they have cardiovascular disease and we don't know about it, we're going to get warnings as we gradually increase exercise intensity. So it's understanding that patient in front of you and what kind of problems there might be with that patient, and thinking about it physiologically and actually paying attention to them as well. Don't get them exercising and don't speak to them and ignore them. You know, make sure they're still kind of cognitively alert, make sure they're still focused, their balance isn't getting worse. You know, keep an eye on your patients, really important. And probably another kind of key point here as well is, you know, one of the things I said before, it's not as easy as just telling someone to move more. You know, it's a lovely message, isn't it? Yeah, sit less, move more. Dead simple. But actually, most people are quite ambivalent about a message like that, and they won't actually make any real changes to their life. Next slide, please. Some of the things, obviously, kind of we need to think about, and obviously kind of educate patients about as well. Things like kind of palpitations, things like kind of fatigue, things like kind of dysglycemia. So we need to make sure we manage these different, we think about these different potential physiological problems, and we educate our patients about them as well. So they actually kind of know about that. That's really, really important. Shortness of breath, we've kind of talked about, and again, you know, we expect people to become shorter of breath, but you know, if it's unexplained, if it's unusual, if it's changing, that's obviously a concern. And so we need to think about how we educate patients about that without kind of scaring them about it. So it's about talking to them, you know, in a sensible way about, you know, exercising and what they should expect to happen. And we think about as well, MSK pain is a really, really interesting one, isn't it? Now, for a lot of conditions, I wouldn't worry too much about a transient increase in MSK pain. I tend to use Vascales quite a lot with patients, not just for pain, but for stiffness as well the next day. So we can kind of track exactly what's happening with a particular patient. And you'll definitely find there are different conditions that respond slightly differently, where you want to keep those kind of pain levels a little bit lower as you're actually kind of going through the start of an exercise program with a particular patient. And usually, obviously, we keep patients around. Quite often, you know, we'll allow kind of 3 or 4 on that kind of VAS scale, sometimes a little bit higher, sometimes a little bit lower. Can we have the next slide as well, please? Okay, this one I'm not going to talk about. I'm just going to draw your attention to it. It was kind of part of the American College of Sports Medicine, one of their papers, and it was essentially about exercise professionals getting patients to exercise, and how do we get as many people as possible to exercise without putting them off. Where's the balance of risk and benefit there? And that's what that slide is actually about. And as I said, there's lots of papers that explain it. It's a nice, simple flow chart for anybody to use. And next slide, please. So, moving medicine, that link I provided for moving medicine, got loads of stuff on kind of active conversations, and there's loads of things been produced around that across the NHS over these last couple of years, which are really, really kind of informative, really good for using with patients as well. And it's about how we communicate. And again, it's not this is used for every single patient. It's about thinking, okay, well, what skills do I have that I can utilise with this particular patient that are going to fit these circumstances and help that patient realise their potential safely. And that's what it's about. It's about finding out a bit more about the person in front of you, including things like kind of open questions, reflections, summaries. So we're allowing the patient to tell their story. We can still kind of control that assessment, but we're allowing them to actually kind of give us the answers and talk about what's important to them. And that's really, really important. And empathy as well. So if we think about empathy, we demonstrate that with things like reflections and summaries. So we shouldn't just be ticking boxes when we have a patient. We should actually listen to the patient, and we should make sure we understand what that patient is trying to tell us. So we can kind of summarize, we can reflect on what they've said. We can have the most empathy of any healthcare professional, but if we don't demonstrate that to the patient, as far as they're concerned, we don't have it. And empathy is really important. We have to listen to patients, and we use these kind of tools to actually kind of do that. One of the things we all do, and we do this in our personal lives as well, resist the righting reflex. So if patients come in, they misunderstand things about kind of exercise, try to avoid just telling them they're wrong. It immediately puts barriers up, and it makes it hard then to actually kind of communicate with them and get a message across effectively. Think about it, you can play this out at home yourselves. Try and correct people all the time if you're having an argument with your partner or any of your loved ones, and see how well that goes, versus not correcting them and actually having a discussion about it and exploring how they feel about particular things. There's a huge difference in outcomes to how we deal with patients and how we actually kind of discuss that. And then we use things as well, we can use kind of tools like kind of the ask, share, ask. And again, it's asking the patient about, you know, what they heard, what do they understand, you know, what do they actually feel? And it's getting more information that allows us then to say, okay, well, actually, you know, maybe this is the way forward for you. And it's a collaborative approach. And it's definitely not judgmental. We shouldn't be judging our patients. We should be helping our patients, and they should be the centre of everything we do. That's mega important. And the next slide, please. I'm going to whip through these next two slides. The next two slides are just around kind of questions that we might use when we're doing kind of behaviour change, motivation, interviewing. Hopefully you've all seen some of these before, and they certainly kind of will feature in kind of courses, online CPD and things like that. So if you could forward through the next slide as well for me, please. So overall, there's probably some important messages that we can give to patients as well. And again, we choose when it might be appropriate. And some of the things like, for example, Dawn was talking about, you know, age is irrelevant and benefits can be gained at any age. That's really, really important. You know, kind of sit less, move more, think about strategies for that. Think about active transport as well. And kind of make walking and physical activity part of your everyday life. There's other people who use kind of behaviour change models like BJ Fogg from Stanford. He uses a really simple model looking at kind of prompts, ability, motivation. And quite often when he's facilitating behaviour change, some of the first two steps of that are actually around kind of the prompt, what prompts someone to do something, and the ability. And the ability might be, you know, say, for example, if we have a behaviour like somebody's not sleeping well at night, not getting enough sleep because they're always looking at a phone, we change their ability to access that phone, you know, by leaving it downstairs. It's a really simple example, but ability is, you know, not just about the physical ability to do something, but it's about that capacity to actually do complete a particular behaviour successfully. And the next slide, please. So, and again, we emphasise with those, you know, for kind of patients, one of the few exceptions, long-term risk to health and not exercising are much higher than risk posed by appropriate physical activity. There's always caveats for different conditions, including some inflammatory conditions, including some neurological conditions, where obviously kind of activity, we need to think about activity and exercise very, very carefully with particular patients. And next slide, please. So this is one I'm just going to talk about very briefly before I'm probably going to hand over to Chris in just a sec. This is something that obviously kind of came up, you know, because of exercise. They've always been a cornerstone of kind of treatment guidelines for osteoarthritis, but the actual effect sizes are fairly small. They're positive, so it's not actually kind of harmful in any way, but it's probably not as good as many people thought over the years. But overall, the benefits of exercise far outweigh the disadvantages. And that's probably the most important thing here to take away. People look at headlines and they think, do you know what? Maybe I shouldn't do this, or maybe this shouldn't be the focus. But we need to pay a bit more attention and think about, okay, well, what are the overall effects of this? And if we're talking about resources as well, we've got things like kind of Trek Education versus Arthritis, and it's got lots of kind of patient videos on there as well, which are absolutely brilliant for supporting patients. And it also has on there, on Trek Education, there's loads of stuff on myth busting as well. So people with osteoarthritis, they've obviously got lots of separate questions about, isn't this going to wear my knee out, and things like that. And there's loads of brilliant kind of material on there to support you in getting your messages across. And the same for the American College of Rheumatology, their recent guidelines, although they didn't find massive positive effects from a disease perspective, overall, again, they recommend exercise. It's one of their strong recommendations. So we just need to bear in mind there's a difference between kind of the research for a very specific condition, but the overarching kind of benefits of exercise and, say, for example, resistance training. And next slide. Okay, what I'm going to do is I'm going to kind of move on fairly quickly for the next few, because I'm going to let Chris take over. I'll let you have a look at this in your own time. But again, loads of resources for this. The Royal Osteoporosis Society, they have loads of absolutely excellent kind of guidelines, patient information, including how to modify kind of common exercises. Say, for example, kind of Pilates type exercises where we definitely need some modification for some of the spinal movements for a lot of our patients. And also as well for healthcare professionals, managing, those patients with spinal fractures and painful spinal fractures as well. Sounds daunting, but quite often those patients can actually do quite a lot fairly early on. So that's incredibly important. And if you want to go on and get more kind of advanced CPD, then people like Lift More do a whole host of courses where obviously they've done a lot of stuff using kind of much more high intensity kind of deadlifts, squats, exercises like that. And the next slides and the next slide. So those are things for you to look over in your own time, absolute contraindications to exercise. And the next slide, please. And guidelines for further reading. If you could just go forward one more, please. There we go. I'm going to hand over to Chris now because I've gone a little bit over time, so I do apologise for that. But hopefully there's loads of links in there for you to go through and read loads of stuff. So I'll shut up now and I'll let Chris get on with it.
Thanks, Steve. This will just be a couple of minutes now on sort of nuts and bolts, really. Obviously, some of the population we're working with will need actual resistance training interventions. We probably need to be a bit less scared of it, really, because the people who need the strength training interventions most are the people who are actually using strength training most, because a lot of their daily activities are very, very close to, if not actually at times almost beyond what they're capable of doing as a sort of one repetition max in gym speak. If we can just go to the next slide, please. This is the kind of thing that you'll see in sort of gym and strength conditioning circles around if you have a strength training goal. It might be maximal strength, it might be hypertrophy, which is muscle building, it might be muscular endurance. And the closer you are to your absolute limit, the more it becomes pure strength. And that's what I mean by, if you're dealing with very, very deconditioned populations, standing up might require some assistance from their arms. So actually, sit to stand is beyond their one repetition max of what they can do just with their legs. So they're already into super maximal loading. So the idea of fearing strength training with those populations is almost nonsensical, because they're having to access that level of intensity on a daily basis multiple times throughout the day. So obviously we need to be careful with how we do that in a more structured sense, and introducing increase in volume, being more reps, more sets, very carefully. As Steve was saying, it might need to be that you start with very low volume bouts and then gradually add another set after a rest, and then the next session add another set. but we are going to be working in high intensity ranges with deconditioned populations, whether we like it or not. And we actually need to keep them there because we need over 80% of our 1 repetition max to generate improvements in bone mineral density, most likely. So once we get somebody a little stronger so they can start accessing sort of muscular endurance rep ranges, higher rep ranges, we may need to change the exercise. Next slide, please. One of the issues that we have is that the vast majority of people who don't engage resistance exercise are unlikely to go to the gym, and we need to be realistic about that. So we're looking at home-based exercise for a lot of these populations. If you think of falls and fractures, that tends to happen because you trip, you miss a step, and then you're either too slow to be able to recover your base of support, or you end up in a position that you're no longer strong enough to decelerate your body weight and decelerate that momentum. Next slide, please. If we think about a lower body progression, we're actually looking outside of gym environment at giving people a series of different exercises. So we might start with a sit to stand from high seat or adding cushions to the seat so that we can do some repetition. And you may start with a small number and gradually build up the number of repetitions that person can do. So it goes from being true strength training more towards muscular endurance training. And we may be able to get them from doing only a couple of repetitions up to being able to do 20 repetitions in a set over a short period and then progress the exercise. And we might be able to gradually progress them through this type of an exercise progression where they finally end up being able to do lunging forwards onto one leg, which is how you would decelerate yourself in a fall situation. Next slide, please. If you don't decelerate yourself enough with your lower body and you do fall, then the upper body and decelerating with the upper body becomes important. So actually upper body push progressions, effectively like a chest press up or bench press progression, is relevant to a falls population or a deconditioned population. So we have a similar progression there for that kind of a movement. Next slide, please. So this is the last one, because obviously very short on time. So we end up in a situation where instead of being able to choose whether we're going to strength train with somebody, whether we're going to do hypertrophy or we're going to do muscular endurance, because some of the movements they would ideally be able to do are beyond their current ability level. Instead, we have to choose exercises within the person's ability where they can do a few reps. Because they can only do a few reps, that will be true strength training. And we'll need to gradually increase what they can do with that exercise until that becomes muscular endurance work. And then we can progress the exercise and repeat the process, which is actually the reverse of how we're taught in sort of regular gym population. So we have this reverse linear periodization model where you will have to start with strength training with these populations and not to be scared of that. Sorry if that was a very whistle stop, it was just a short on time.
Thanks very much to both of you, Steve and Chris. That was really useful. Lots of information there. And as we've already said, we will share the slides afterwards so people can click through to all those links to find out a little bit more. Also realised I didn't say at the beginning that if you've got any questions to use the chat box, and our speakers will and Kate will keep an eye on that and will respond where possible. We're going to take a comfort break now. I make it 2:02, so we'll come back at 7 minutes past. Thank you. Okay, welcome back everybody. Hopefully people are getting back in front of the screen. Thank you for making it this far. And we got two more amazing speakers coming up. We're going to start first with Dr. Fiona Duncan. Fiona's going to tell us a bit about a reconditioning initiative for care home residents in North Devon. Fiona, I'm hoping you're there because I can't see anything.
I'm here.
Okay, fab. Thank you.
Hi, everybody. Can you hear me okay?
I can.
I've got
Yeah,
building
I can,
work. I've got really loud building work going on outside, so I've just put the
Typically.
headphones in, so hopefully it'll be okay. All right, really nice to see everybody. So yes, I'm going to talk about our reconditioning initiative that's happening in North Devon. So next slide, please. So this is just a bit about me. I work as a GP and a specialty doctor in geriatrics in North Devon. I do a lot of work on enhanced health and care homes as well as anticipatory care. So sort of fully involved in frailty and care of older people in this area. Next slide. So a bit of background to our project. You probably heard already from some of the other talks about deconditioning. So we know that this is a syndrome of physical, psychological and functional decline that occurs as a result of prolonged inactivity. So COVID has been one of these things that has led to a huge amount of deconditioning in our older population. It's been reported, there's a really good paper here from Public Health England, it's worth reading here about the impacts on people over the age of 65. And what we know from this is that it's people, older people and those with dementia and living in residential settings that have been most affected by deconditioning. We know that it leads to falls and we know that there's a big impact in terms of cost to the NHS as well. Next slide, please. So local relevance to North Devon. So we've got lots of care homes in North Devon. We know that lots of our local residents are affected by deconditioning. We looked at what was happening in the care homes in terms of activity levels, and it was very variable. Some had coordinators, some didn't, some were doing very little, some were doing a lot more. So we looked at this gap analysis and we recognised that really we needed to be supporting care homes to address deconditioning in our local residents. Next slide, please. So we were lucky to be able to access some funding from the Ageing Well Fund for enhanced health and care homes for this work. Next slide, please. And what we really wanted to do was get people to be more active to address deconditioning. So we wanted to increase activity levels amongst our residents in local care homes, improve physical and mental well-being, and educate not only residents but visitors, family members, staff, everybody on the importance of keeping people active. And we wanted to implement a sustainable model, so not just dipping in and out. We wanted to make some sustainable changes to continue beyond the programme. Next slide, please. So this is our team. I would point out that we're on the back row, not the front row. So left to right, we've got Andrew, Jeffrey, our activity facilitator, me in the middle, and then Liv Sanford, our coordinator. So this is the team. It's quite a small team, and we've been working on this together. Next slide, please. So our reconditioning initiative has had four aspects, or has four aspects that's ongoing at the moment. So number one, top left there, you can see Andrew with his little dog. He doesn't bring the dog into the care homes, unfortunately, but we are working on that for some pet therapy as well. So Andrew goes around all of the care homes in our area and delivers some personalised activities and advice, but also group activities, all aimed at actually educating the staff to be able to continue this work in his absence. So it's not just what he's doing there and then, it's really encouraging them to do things in between his visits. Number two is our fund for personalised support to care homes. We've had 50 out of our 56 care homes in North Devon successfully apply for this funding. It's been allocated in terms of bed number to all CQC registered care homes in North Devon, and this is funds to be able to, for the care homes to be able to choose what they want to spend it on to address the needs of their set of residents. And then number three is education and training. We've organised several PCN care homes teaching sessions. So we have PCN is Primary Care Network. We have groups of allied healthcare professionals working in our care homes as part of primary care and enhanced health and care homes. And so we've organised several teaching sessions, and we've had falls, falls prevention, and we've had one on specific exercises to give to older people as well so far, and we're about to have one on hydration and nutrition as well. And then number 4 is project coordination. So we've looked at measurable outcomes. I'll come on to them in a minute. If we just go on to the next slide, please. So this is a bit more about our activity facilitator, and I would just say that the residents involved in this project have kindly given their permission to share these photos. The photos that you'll see today are of real people in our care homes doing these bits and pieces. This is Andrew working with one of our ladies doing some hand pedaling exercises here. So Andrew's doing a holistic review of activity in each care home, exactly what's going on, trying to look at the gaps and where things could be potentially improved. He's given guidance on personalised exercises. He's also signposting to activities available online and within the local community, because lots of residents can actually leave to go and do things as well, and linking in with local organisations and volunteers, and working with staff and the healthcare professionals just to promote awareness of how to increase activity. And this isn't just doing specific planned activities. This is actually building it into normal activities of daily living. So encouraging people to participate in getting dressed. Quite often there's a big rush to get everyone up and out and about in the care home. Actually, if you can just spend a little bit longer with each resident to enable them to do some of the stuff for themselves, there's evidence that can make a really big difference. So we've really been sort of pushing for that, getting people to walk a little bit further, walk the long way around to the dining room rather than the short way, just increasing slight walking distances, this sort of thing. Next slide, please. Personalised funding, I've mentioned that already, allocated per care home bed number. Next slide, please. And education. So this is one of our teams having a session. And next slide, please. So in terms of outcome measures, residents, we've looked at, we've sent out surveys at the beginning of the project looking at activities of daily living, walking distance in the care home, time spent on feet, participation in activities. We've also used the Bartel Index for all residents involved as well. And we've looked at well-being using the World Health Organization 5 Wellbeing Index. And we're doing this, we've done this at the start of the project, and we're due to do evaluation shortly. So we'll be repeating all of this very shortly. Next slide. In terms of outcome measures on staff and care home organisation, we're looking at staff awareness of deconditioning, the importance of promoting residents. Have they got posters up in the care home, leaflets, suggestions on what family members can do when they come to visit? And also we're looking at personalised activity plans for all new residents. Have they got that in their care plans? Next slide. And then our PCN primary care network care homes teams, we're doing some education there and looking at these outcomes before and after, and building into the personalised care and support plan that our care homes teams do. We're building in an activity question, and we've done that in 2 out of our 4 PCNs so far. So that's already in the care plans. That's looking good. Next slide, please. This is we're aiming for this to be a sustainable approach. This is all on non-recurring funding, as a lot of these projects are, unfortunately. So we're really looking for the care homes to take home these messages and you know, sustain some of these changes. Next slide, please. So this is the fun bit, because we get onto some photos now. So this slide shows what some of our local care homes have been doing, what they've been spending their personalised funding on. So one of them has bought an accessible bus to get people out and about, and they've taken residents out daily for walks along the seafront, also to a Dire Straits tribute concert, which I think is amazing. And we've had visitors into some of the care homes. The lady in the bottom left there, I am assured it wasn't a live reptile that she was holding, but lots of interesting experiences to stimulate the mind, as well as getting people to be physically active. And then lots of purchasing of really basic equipment that can be used for fun games to promote activity, as well as gardening as well. The bottom right photo there shows that one of the care homes used their funding to make these beds, and the residents have since planted things and they're growing their own vegetables. Next slide, please. So this is about the National Reconditioning Games, which I'm sure you're all aware of. It took place. We ran it in February actually this year. I know it took place at different times in different areas. So we set some cycling and walking challenges for all of our care homes, and they could compete against one another to see who could win some medals. And so we measured out distances in the corridors that would correspond to a certain distance on our local Tarka Trail and the Southwest Coastal Path if people walk the strip a certain number of times. We had some volunteers coming in to be part of this as well. Next slide, please. And these are just some people participating in the challenges, and they really entered into it with a great sense of fun. Next slide, please. At the end of these challenges, we then visited the care homes to present medals, and we had the national anthem playing and gave them their medals and certificates, which went down really well. And people were actually really moved by it, and pleased to have some reward for all their amazing efforts as well. Next slide, please. We ran similar challenges for our NHS OPIC teams, older persons integrated care teams, and we competed to walk certain distances. My team lost, unfortunately, but our dogs were basically walked around the clock early in the morning before work, late at night, in lunch breaks, and they were thoroughly fed up by the end. Next slide, please. One of the projects that we've been involved in as part of this reconditioning initiative is the Move and Groove project. So we've been working with intergenerational music makers, a non-for-profit organisation, and we've linked up local primary schools and care homes. We've done 2 settings so far. To participate in intergenerational music and movements. These have been 6-week pilots. They've been really successful so far. We're just currently evaluating them, but all the feedback that we've had is lovely, and I've been involved in leading a couple of the sessions, which has been really great fun. What's nice about this is that it's not something being done to older people. This is something that people are participating in, and they're getting a real sense of well-being in terms of giving something back and helping some of the children out. And we're hoping to roll this out to some further care homes independently in the next few months. Next slide. We're also running a musical sports program, which is a follow-on. So for the 2 care homes that have had Move and Groove, quite often when you step out again, things just come to a halt. But we really want to promote care homes independently hosting children for ongoing intergenerational activities. So we're running some interim projects, and this is some photos from our musical sports program that Andrew's been running, doing some resistance training with the children and the older people there. And also we're sending out posters each month advertising different sporting events that are happening in the world and encouraging care homes to get involved. So this was our example from May. We had a care home FA Cup final poster up in all the care homes, and you can't see very well, but there are some little suggestions of what people can do to be part of that. Next slide, please. Other service developments, we're making an online toolkit for care homes. So this is a central resource hub. This is for residents, carers, health and social care professionals, anyone involved in looking after older people in care homes or older people themselves. And we're putting monthly updates of our EHCH work on there as well. This came about because we sort of talked to our wider steering group about what else was missing in this area, and lots of care home managers said we just want one place to look for everything. At the moment we have to go to the council website, we have to go to this place, that place. If we can just go to one place to find everything that we need, that would be helpful. So this is what we're working on at the moment. Next slide, please. Other collaborative work, we're working with our health and social care team. There's a team of nurse and therapy educators, so they're involved in our PCN teaching sessions. We've got hydration and nutrition coming up. We're hopefully involving a local chef as well to look at changing some of the menus in care homes. We know that in care homes, a lot of people are served foods very high in carbohydrate, very low in protein, which is really relevant for those with sarcopenia, of which there are many in care homes. So looking at increasing the protein in diet. And then in terms of other future projects, we've actually today just started our music therapy for dementia. I went along just to check the first session was going well. We've got a guitar player coming in to do some group sessions, playing nice, relaxing Spanish guitar. And what was lovely is I saw one of our nurses today who was visiting, and she said, wow, I've never seen Mrs. X look so relaxed. Normally Mrs. X is a wonder. She's got advanced dementia. She wanders around and is in a sort of constant state of agitation, sadly. And actually she sat and listened to the music for the entire hour session, which is great. We're also doing a sarcopenia pilot in one of our care homes. We're using a hand strength dynamometer, I can never say that word, to measure hand strength in all of the residents to identify roughly how many may have sarcopenia, and then looking at what we can do with those that we identify with this. We're hoping to get a postural stability instructor in as well as our therapy team, and then we'll be looking for funding to try and have a PSI for all of our care home residents in North Devon. That's another thing, another funding pot to chase after at some point. Next slide, please. This is Healthy Aging in North Devon. So this is a group which consists of older people, of health and social care professionals, the voluntary sector, hospital, primary care, everybody really. We've had some very large workshops looking at how to improve care of older people in North Devon. I've been quite heavily involved in that. It's going really well. Check out our website at the bottom there. There are monthly updates. We've had some brilliant community activity projects taking place. We've also shared Live Longer Better licenses. We've started the FAME program is due to start soon as well. That's Falls Management and Exercise program in all of our One Devon communities. So that's all of the main centres in North Devon. Okay, and next slide, please. This is relevant to some of the work that we're doing, but also other preventative work that I haven't covered here, but it just shows the decrease in growth of admissions in North and West Devon with our preventative approaches compared to elsewhere. Next slide, please. And then we've had some lovely testimonials on our reconditioning initiative so far. We've had sort of a lot of the visiting healthcare professionals are so pleased to see people actually up and using seated pedals and doing bits and pieces rather than just, you know, when they visit, often people were just sat in the lounge not doing very much before. They are actually, you know, noted to be a lot more active since we've done this. The carers are loving it because they're participating in this with the residents. Often we have you know, we'll have two seated pedals side by side and a carer will be doing a little race with one of the residents. And I think that improves carer wellbeing as well, which is really important. And the residents have particularly enjoyed seeing the children. That's been the highlight, really. So we're really hoping to expand that and ideally get all of our care homes linked up with local schools eventually. I think that might be, is that it? Yeah. Oh, and I'll just finish actually with this slide because I just want to show you this lovely couple live in one of our local care homes, and as part of the National Reconditioning Games, they walked 5 kilometres one day, and you can see they are very frail, and the lady walks with a trolley, but they were really keen to get the distance up for their care home. So rather than getting their taxi to the pharmacy, they walked a 5 kilometre round trip. So I just thought this is what it's all about, really, and I feel like they're very inspirational. We should all try and be like them as we get older. I'm not sure how much I've kept to time because I've not timed myself, but have we got time for questions?
I'm going to suggest we keep questions to the chat box if that's okay.
Course, yeah.
Just again, we're sort of bang on time at the moment, but thank you, Fiona. I certainly was kind of scribbling down various sort of ideas and things that you mentioned there, and kind of lessons learned from your project. I hope will help others in the room. So thank you so much for that. That was really super helpful. I certainly haven't heard of the National Reconditioning Games, but I'm going to be Googling that later. So that was definitely one for us to have a look at. Thank you.
Lovely, thank
you. Okay, moving on to our final speakers. Chipka and Rachel. I'm not sure who's Rachel, is it? Who's coming first?
I'm coming first. Thank you. Next slide, please. So we're here today introducing a kind of intervention that we have been developing for the last 2 years. I'm going to sort of race through some of these slides because really everyone else has set the scene perfectly in terms of aging in the UK. But yes, we now have more pensioners in the UK than we do school children, and that is sort of rising. But our whilst life expectancy is, people are living quite a long time, although it's been sort of decreased recently potentially due to COVID, but other things. Years in good health is are declining. So, and there's huge inequality in terms of sort of our aging outcomes and experience of aging. There was a report recently from the Centre of Aging Better, or Better Aging, I always get it wrong, that sort of described the experience of aging in the UK and the issues around ageism as well. Next slide, please. So the causes and the recommendations. So obviously the pandemic has played into some of these things, and as we've sort of established in previous presentations, there were some, for instance, I read a statistic that in the over 75s there have been a slight increase in activity up to the pandemic, but that has long, been lost since the pandemic. So yes. The pandemic has had an impact, but also there are other risk factors associated with poor aging health. So poverty is a huge one. Our state pension is one of the lowest in Europe. Inactivity, as we're all discussing, obesity, alcohol and smoking are also huge factors. And the government have had various select committees look at these things. So House of Lords Select Committee had a look and made some recommendations in 2001, looking at particularly strength and balance with highlighted as a really key area, increasing sort of access to gym and leisure centre, so making things more open and more appealing to older adults. Active travel that has been sort of discussed, sort of getting off one bus stop early, those sorts of things, and really big and very relevant to what we're going to be talking about, promoting healthy living across your life course. So sort of recognising healthy aging habits and things that can impact your aging outcomes from a kind of earlier age as a kind of intervention. And that's where our ethos with this project is the earlier the better, but never too late. So next slide, please. So this brings me more specifically onto what we're doing. So Dr. Yitka, so she established the Aging Well public talks, which are public talks that run in Milton Keynes by the Open University every year. And she's had, in the 3 years they've been running, I think it's 3 years, but correct me if I'm wrong, Yitka, she's had over 80,000 people engaged in the talk series. So clearly people are interested in this. And I know that I've now been following lots and lots in the last couple of years, following lots and lots of Aging Well news, and it's featured only the other week. There was a big article in the Times that was in the magazine section. So people are very interested in aging well, and as our population ages, obviously more and more people are going to be interested in this. So these Aging Well public talks build on the 5 pillars of aging well. Those are nutrition, hydration, physical, social and cognitive stimulation. And whilst we know obviously that we will all age, as we've established, it starts happening from our 30s, which is an uncomfortable reality. We have some degree of control over this. So studies have shown that 70 to 80% of our aging rate until the age of 80 is determined by environmental factors. So it's not all down to genetics, and these are things within these realms of nutrition, hydration, physical and social and cognitive stimulation. So clearly the importance of aging well is a sort of globally important, as is recognised with the UN Decade of Healthy Aging. And so Yitka sort of has been working on this obviously for a long time. It's her sort of academic specialism, and she wanted to bring this to a larger audience. And I happened to be working on a documentary at the time about how to live to 100 with Jon Snow, and we started talking, and this was just over 2 years ago, and we started talking about how we can engage a larger audience in aging well practices that is a kind of intervention before frailty. So this is directed at sort of 50 plus, and sort of trying to intervene and positively motivate people, and also drive a conversation that aging or older does not mean frail necessarily, and that we can challenge some of the stereotypes associated with older people, because attitude makes a big difference as well in terms of your personal aging rate. Literally, you are as old as you feel. There is evidence to suggest that your attitude towards your age really impacts your walking speed and various other things and cognitive abilities. So anyway, we want to challenge lots of these stereotypes, but also empower people to take some kind of action that will impact their aging outcomes. And I'll hand over to Yitka at this point. Next slide, please.
Thank you so much, and thank you all. It's just fascinating to listen to Dawn, Steve, Chris, and Fiona. It's been a super journey through frailty and managing frailty, and I just would like to recognize that. Because when I kind of get onto what actually is the Aging Well Pledge, I really would like to stress that it links with everything that has been said by Dawn, and with the model around disease, time, and disuse, because the disuse is really the problem, and then followed by the sedentary behavior that also affects hugely how we feel overall, but it also slows down the metabolism that already is slowed down due to age-related changes that are absolutely natural. So this double slowing down is sometimes also enhanced by dehydration. And as we know, you probably agree with me, but the most older adults I know are dehydrated. Most younger middle-aged adults are often dehydrated as well. And the dehydration then kind of contributes to other difficult situations that happen around medication, around pharmacotherapy, around avoiding or trying to avoid side effects of medication, which is prompted by dehydration and sedentary behavior on top of the already happening age-related changes. So this is kind of where this project is fitting the gaps. And throughout the Aging Well Public Talks, we've been creating bridges to and with members of public to kind of bring all the research evidence that is available to people who really need it most. So making the research findings available. And the pledge today, the Aging Well Pledge, is a direct result of 4 years of work of kind of running these Aging Well Public Talks across the UK. We have also heard about sustainable models and about education that Steve, Christopher, and Fiona touched upon. And this is another aspect that this pledge, this project is bringing along as well. We are going to ask people to adopt simple behaviors associated with healthy aging. So along the 5 pillars, the nutrition, hydration, physical, social, and cognitive stimulation, we use this as 5 areas under which we slotted 3 or 4 actions that can be easily done. It is an expert-led pledge, so we worked with experts in nutrition, around hydration, around movement, and around social and cognitive behaviors. And we have devised simply actions that can be done, that can be easily integrated into what we do in the day, and people can choose. We're going to go to the actions in a minute, but we will ask people to adopt these and stick with them, at least one of them, and stick with them for 30 days. And can we go to the previous slide still, though? Thank you. So we will ask people to pledge for 30 days, and we will also use behavioral science, and we have worked with specialists in behavioral science to understand whether the pledge as it is, or as it ideally might need to look like, is able to power that change in routines, because we believe that if we support people to change routines within those 30 days, those new behaviors will be then easier sustained. And we will measure this via 4 short surveys. We will measure first survey will come at the beginning of the pledge, where we will try to assess baseline behaviors and readiness to change. At the end of the pledge, after 30 days, we will ask people to tell us how it went and what did they pledge for and how did it go. If it did go well, why was that? If it didn't go well, if they can tell us how it would need to be set up for them to make it work for them. And then we will have a survey at 3 months after the pledge finished and 9 months after the pledge finished to really understand whether the new routines have been sustained, how long they were sustained. And if we're really aiming for the long-term sustainability in behaviors, in changed behaviors, how does the pledge ideally needs to look like to facilitate this? We will work with participants, of course, the pledgers, but also with organizations that partner with us for the pledge. We currently work with the NHS, Age UK, in diverse regions, and Age Scotland, Age Northern Ireland, and Age Cymru. We also work with carers organisations across the UK, Carers Trust, Carers UK, and more regionally based carers organisations. We work with organisations supporting volunteers, care home members of staff across the 4 nations. We work with GP practices, we work with social prescribers, we work with local councils, with health boards in Wales. The list is quite incredible, and we currently have around 150 partners and counting, because we're still kind of advertising the pledge that starts on 1st of September. We really aim to create a community of people that are empowered to take charge of their health outcomes, and we're trying to do this in a way that we hope is fun and can be done with others. So creating community of pledges, supporting each other, and also we are the main aim here is to really help people engage with their health and well-being, because if they do, it will be also easier for them to be supported by the organizations, and there are many and charities that offer incredible services and incredible interventions in local areas across the UK. But very often we hear from them that they know there are people behind these walls that need their help, and they are not able to come out. So we really hope the pledge can also work as the stepping stone, the practical stepping stone that allows and supports people who might have been de-skilled, like we all were during the COVID pandemic, to come easily out of the house and join a group that's meeting 2 blocks down the road. Because for some of our members in the community, this is a huge leap that they're not ready for. So we work with formal, informal carers and organizations who support formal and informal carers. As I said, we work with organizations who support volunteers, as we feel that the pledge can be done together. And we also work very closely with Campaign for Learning, which is a national charity, UK-wide charity that supports social inclusion through learning. And we're really hoping, bringing over the years an intergenerational component, so that the pledge can become the fun thing to do for families, where grandparents pledge with their grandkids, and we have the adults in the middle that are incredibly busy, but perhaps will have no other way to go other than say, oh yeah, okay, okay, I'll pledge with you. So we're trying to do this in a fun way, engaging way, and as we said, we hope to engage people with their health and well-being. Can I have the next slide, please? Thank you. So in more detail, these are the actions we're going to offer. We have tried not to be too prescriptive, because one thing we've learned with the Aging Well Public Talks and all the feedback and evaluations we have done on that resource is that people like to adapt a product to their lifestyles, to themselves, so that they feel it's tailored, or it enables them to tailor the product a little bit. So we were trying not to be prescriptive here, and just perhaps go along healthy principles when it comes, for example, for eating, for nutrition, or drinking, or movement, where we are kind of suggesting that people can do what they can do. There are two messages that I would probably like to associate with the pledge, and it also resonates with what Dawn, Steve, Chris, and Fiona were talking about earlier. It doesn't have to be a huge workout. It doesn't have to be a huge step. It can be a small step, but it needs to be a regular step. So people, we do not need to climb a mountain. We can make a small step, providing that we take this step every day regularly. And we don't need to do this alone. There is community that will kind of grow and support each other. And we will also support all pledgers with 2 weekly emails where we will share short interesting facts, short quizzes, short films, short podcasts to bring an educational element as per why eating, drinking, moving, engaging, connecting and thinking are incredibly important as we age. And we will also, we have also started working with a third sector provider, and we're preparing a WhatsApp app where people can put the number in a WhatsApp and say hi, and there will be a pledge coach that will embark on a tailored individual journey and kind of craft out a tailored individual plan for each and every pledger who would like to use the pledge coach. And it will also enable people to invite their family members and friends to look how they pledge, how they're doing, and to check in daily basis or weekly, whatever people prefer, for people to feel supported. We did try the pledge as a project team. It is a very interesting experience, and one thing we started to realize is that it can be quite lonely. So any support that people can get and feel they have is usually very welcome. Can I have next slide, please? Thank you. So we hope that this will boost the long-term health and well-being. And if I'm very honest, this hasn't been done before. Pledges were done before, pledges that usually look at one aspect, one specific behavior. In our case, we're piloting a pledge that's looking at 5 different behaviors, which also has been quite a unique challenge for our colleagues, specialists in behavioral change, who were kind of leading the work package on designing the surveys. As you can imagine, if you do research, there are quite a few pitfalls that we kind of needed to overcome. So we hope that this first year of the pledge, the pilot year, will be our first year, and we will be able to find sponsors to pair with, to partner with, to power this initiative to be available year after year after year, so that we really can contribute to better connected and healthier and happier nation. And as we said, it is free, expert-led resource initiative. We're also working in the background on engaging ambassadors across the 4 nations. I am super pleased and honored to say that Dawn has accepted to be our ambassador. So we're thrilled working on this together. And we really feel that this vision for a healthier and happier nation is needed. And as a team, we feel that together we have an incredible opportunity to do so. So thank you all so much. Thank you for your lovely comments in the chat that I just saw in the corner of my eye. Please do get in touch with me and Rachel, and or if it is okay, Kate or Kirsty, to share the list of participants who have expressed interest to hear from us, we will certainly be delighted to contact you, and we're happy to chat in more detail. We have another slide here about team and funding. So the team is very multidisciplinary. I've said we worked with specialists around nutrition, hydration, physical activity, and behavioral scientists. We have also, outside of academia, worked with care homes that are UK-based. Age Scotland is our project team partner. They have been very, very close since the inception of the pledge. We, as I said, we worked with the NHS, we worked with carers organisations across the UK, with Age UK, Age Northern Ireland and Age Cymru as well. But we also work, as I said, with Campaign for Learning and several other stakeholders and GP practices who decided to stay close and really be part of this quite exciting venture. Well, I believe we say innovative research and to ride this ride with us. So if you would like to stay close, please do let us know, because we also work, for example, with Turning Point UK. And as you may or may not know, they work very closely and they have a team that's, for example, specifically looking after people with learning disabilities and their carers. And we know that people with learning disabilities do not in general age very well, that the aging is faster due to biological reasons and the condition that is often behind the learning disabilities, but also because they are not always as stimulated as they could be. And the same goes for their carers. Often their family members and very often parents who are aging as well. So aging carers and aging adults with learning disabilities are another group that needs an extra support. So with people from Turning Point UK, we have agreed to work closely through this first pilot year to devise a strategy going forward in bringing the pledge to the communities that need it, but they often need extra adjustments, like, for example, developing easy reads, summaries, or easy read documents. So if you would like to work closely with us and kind of join us at the round table of discussions about launching this pledge, we will be super delighted to have you. So just get in touch with us. Can I have next slide, please?
Also, I'm conscious of time. Are
Yes.
Are you able to kind of swiftly move through it? Thank you.
Yeah. Thank you. There is also incredible work that Rachel has been doing behind the scenes on engagement, on engaging with ambassadors and preparing engagement packs, working on the website and everything. So if you're happy for us to email you all the information and website once ready, which would be probably within the next 2 weeks, do let us know. As we said, it's an expert-led, evidence-based pledge initiative, and we're super keen to work together because we're stronger. Thank you so much.
Thanks, Yitka. We can certainly add information to the kind of follow-up email that we'll do as part of the event anyway. Thank you. And obviously we'll share the slides so people will get your email address on there. Okay, swiftly moving on. I'm determined to get us finished by 3. So I wanted to use the opportunity today to mention a couple of our programs that we've got here at Get Berkshire Active. I realise we've got people outside of that geography, but yeah, we wanted to share a little bit about these 3 programs. They are the ones that are most relevant to the topic today. All of these are externally funded, and that generally then determines exactly where they take place. So we're funded to deliver our Ever Active programme in Reading and West Berkshire. This programme focuses on less active older people and those living with long-term health conditions and disabilities. It focuses on chair-based, community-based wellbeing sessions. So drop us a line if you want to hear a bit more about that. The reconditioning programme is at the moment only Reading based. We would love to see this in more areas. This one is a one-to-one support programme for older people. These tend to be individuals that are less mobile, more frail than those engaging with the Ever Active programme, so finding it more difficult to get out the house, probably struggling with their confidence and often struggling with mobility and strength. And then finally, our active medicine programme aligns really well to the points that were covered by Steve and Chris around behaviour change. So this programme involves training that aims to equip professionals with the knowledge, skills and confidence to promote physical activity through everyday conversations. And depending on your needs and your role, we have different training options available. So again, if you want any more on any of those, then please drop us a line. I also wanted to use today as an opportunity to plug our Live Longer Better hub on our website. We've had a bit of a refresh recently, so we try and use this page on our website as a bit of a resource hub. So you'll see the presentations on there from today's event, but you'll also see some presentations on there from previous events, for example, and other bits and pieces too. Okay, we're going to finish with a couple more Slido polls. So if you can grab your phones again for and navigate to slido.com, hashtag LLB01. I realise this might be a bit of an ambitious question to ask, but we're going to go with it. And also, when you answer this one, if you can just put the area, so whether that's county, local authority, just something to give us an idea of maybe where you're from, in brackets when you're answering this one. So if you had a magic wand, what systemic change would you make with regards to preventing, delaying and managing frailty? I imagine our speakers today have also given some inspiration maybe on what we might say here. I can see lots of people are typing. That's fabulous. Thank you. Super. Someone started us off. Well done. If you could put your area in brackets when you write, it would just kind of make it a bit more helpful for us. Obviously, we're being Berkshire based. Thank you. Super. Oh, wow, it's automatically doing something snazzy for us there as well. That'll be helpful because I realise with lots of people on the call, this is going to obviously generate a lot of responses, which is great. Thank you, everybody. Keep going. Obviously, we can take this information and help and attempt to sort of group it into themes and integrate it into some of our work and conversations and collaborations with partners. It's kind of moving too fast for me to do any attempt of reading some of these, but yeah, it's definitely lots of, I imagine there's lots of similarities even between different areas. Funding is always, yeah, always a big one. And education, yeah. Okay, a few more seconds on this one. Brilliant. If you finish the one you're on, try and capture as much as we can. Thank you. Okay, I'm going to move on. Apologies if you're mid sentence. So you'll recognise this one, same question that we had at the beginning. On a scale of 1 to 10, with 10 being the most important, how important is physical activity to you with regards to preventing, delaying and managing frailty? This is great, thank you. I can see there's still lots of people responding. Last few seconds on this one. Okay, I'll move on, thank you. And again, same, but in terms of confidence. So on a scale of 1 to 10, how confident are you in having conversations about and or prescribing physical activity with the aim to prevent, delay and manage frailty? Thank you. Hopefully some of the fabulous points raised today will help with some of this. Okay, last few seconds on this one. I can see there's lots of people still responding. Thank you. Okay, going to move on. And finally, we would really appreciate it if you could take a couple of minutes to give us your feedback about the event. Kate hopefully should be putting the link to the survey in the chat box now, or if you really want to, you can use you can scan the QR code that is on the screen. That will take you direct to the survey. I did my best to keep it as short and concise as possible, and obviously it really helps us to shape these events in the future. We welcome you to stay connected, keep in touch with us. If you're not already signed up to our newsletter, you can do that via our website. That is one of our main kind of outlets in terms of sharing details of these events. And yeah, clearly, if you've not already had a chance to look at our website, you'll also find us on social media. And then just one final thank you. Thank you to our fabulous speakers. We really appreciate you giving up your time. And thank you, everybody, for attending today. Enjoy the rest of your day, everybody. Thanks, everybody. Thanks, Dawn. Thanks, Steve. Thank you. Thanks, everybody. Thanks, Yitka.
Take care, everyone. Thanks a lot.
Thank you. Oh, Caroline, we'll put these slides, it'll come out in an email and we will put it on our website. Kate, it worked. Your military agenda. We did it.
Oh dear.
You're an amazing team. It was absolutely fabulous.
Thank you, Yitka.
Guys. Thank you so much.
Thank you for joining us.
We'll be in touch with all the materials.
Yes, thank you.
Yeah.
Thank you. Have a lovely afternoon. Bye.
And you,
Oh,
bye.
thank you.
Well done. I can see you put the link to the survey in there.
Yeah. Thanks for reminding me, even though I had multiple post-it notes everywhere, I nearly forgot. Oh dear. Funny.
Okay, I am going to dial off now and go and collect
Okay.
my daughter from school. So
Yeah.
I'll catch up. I'll be back online later. I'll see you then.
Okay, see you later.
Bye.
Bye. Oh, I can't hear you, Brett. You're on mute, I think.
So I said, I think we can shut the meeting down now. I'll give you a quick buzz.
Yeah. Okie dokie. Speak to you in a bit, Brett. Bye.